Good morning, ladies and gentlemen. I am Cheng from National Taiwan University Hospital, Taipei, Taiwan. My topic today is the role of percutaneous pulmonary artery cannulation in extracorporeal life support for acute cardiac failure. Background. The pulmonary artery cannulation during peripheral venous arterial extracorporeal life support has been shown to be effective either for indirect left ventricular unloading or to allow the right ventricular bypass. Purpose. This case series reports the result of PA cannulation during ECLS management for acute cardiac failure in a single institute. Method. All consecutive patients receiving direct or percutaneous PA cannulation from January 2017 to December 2020 in one institute were retrospectively reviewed. Based on the specific hemodynamic needs of the patient, PA cannulation was applied with ECLS for isolated LV unloading or RV support, as well as by dynamic measurement including initial PA drainage followed by perfusion through the same cannula. The configuration of ECLS. The PA cannulation is used as an additional draining cannula to enhance LV unloading. The LV unloading was assessed by transesophageal echocardiograms in relation to LV distension or dimension, as well as by looking at the signs or blood stasis and the left heart valve openings. The same PA cannula might provide blood flow into the pulmonary artery in the case of RV bypass or hybrid VA ECMO. The right atrium was cannulated through the femoral vein as the inlay arm and the PA cannula as the outlay arm, enabling isolated RV support. The cannulation of pulmonary artery was carried out either directly or percutaneously according to the timing and the clinical situations. For direct PA cannulation, which was carried out in the operating theaters during full or partial sternotomy operations, two purse-string sutures were placed on the anterior wall of the pulmonary trunk, 2 cm downstream from the pulmonary valve and the root. A 19 or 21 French cannula, according to the patient's body size, was then introduced into the pulmonary artery, tunneled into the subxiphoid space, and connected to the ECLS circuit. As an alternative method for direct cannulation, a vascular prosthesis was anastomosed to the main pulmonary trunk and tunneled at the subxiphoid space, allowing postoperative decannulation and prosthesis ligation without the need of reopening the sternum. For percutaneous approach, a right internal jugular venous access was established using direct ultrasound visualization. A soft guide wire was placed in the pulmonary artery with fluoroscopic confirmation. Along the guide wire, a guiding catheter was positioned in the same location as the guide wire tip. After withdrawal of the soft guide wire, a super steep guide wire was advanced within the guiding catheter, which was finally removed. Through the stepwise dilation of the access to the skin, a 19 or 21 French cannula was finally positioned along the super steep guide wire in the main pulmonary trunk or right pulmonary artery, after which fluoroscopic and transesophageal assessment could confirm the adequate position. The fluoroscopic picture showed the percutaneous cannula positioned in the main pulmonary artery from the right internal jugular vein. The transesophageal assessment also confirmed the adequate position. The results. The table presented the demographics, operative characteristics, indications for and the configuration of ECLS, and additional assist devices. The table presented the major in-hospital complications and hospital outcomes. In summary, 30 patients presenting with acute cardiac failure of various etiologies were supported by the hybrid ECLS mode. 23 patients were male. The mean age was 50.9 years. Your score ranged from 14 to 70%. The PA cannulation was performed percutaneously in 11 patients. The PA cannulation was used for indirect LV decompression in 16 patients. The management of dynamic ECLS was performed in 3 cases. The mean ECLS duration was 5.3 days, ranging from 3 to 124 days. Successful weaning from circulatory support was achieved in 10 patients. 4 patients who were not successfully weaned from ECLS finally received a cardiac transplantation. The in-hospital mortality rate was 40%, which included 1 death of a massive cerebral hemorrhage while the patient was on ECMO, 7 of septic shock following successful weaning. 18 patients were eventually discharged. They are alive and in good clinical condition. Conclusion. First, the present study presented that the PA cannulation, especially percutaneously performed, was feasible and safe without major complications, and by which LV decompression as well as isolated RB support during ECLS could be effectively accomplished. Besides, the common clinical complications during the conventional ECLS mode could be reduced with such a hybrid ECLS configuration. The dynamic or adjustable management of ECLS could be achieved according to the specific functional and the hemodynamic needs of the patient. Finally, further investigation is required to confirm the safety and efficacy of such an ECLS configuration and management in the larger patient population. I am Cheng from National Taiwan University Hospital. Thank you very much, ladies and gentlemen.